And good morning, I'm Dr. Duke Majan. We're here at the Duke Spine Institute, Surgery Center, Viera. Today we're going to be performing on January 31st, 2023, our first surgery for today. Our patient presents to us with herniated discs, degenerative discs, and some DISH, what we call DISH, which is diffuse idiopathic skeletal hyperostosis. You could see it on her x-ray. She's got some beaking in front of C5-6, C6-7. But on her MRI, she has a large herniation at C7-T1. C7-T1 is almost impossible to reach anteriorly, but we did preoperative x-rays, AP lateral, with shoulder pulled down, and we were able to see C7-T1 across the collarbone, which usually limits the anterior access. So we decided to try the surgery anteriorly with the endoscopic approach. This is the Duke laser disc repair. We're going to be treating C6-7, C7-T1, with C7-T1 as a large herniation off to the right, interacting with the right T1 nerve root, and C6-7 is the first disc we're going to treat. Before I started, I did a lateral x-rays to make sure that we could reach C7-T1. Like I said, it's very, very difficult. We did that in the operating room as well with a shoulder pull, and it seems like we can proceed. So we've accessed C6-7 first, and you can see it on the lateral x-ray, right, Henry?
Yes.
Jordan, show us C2. Can you see Jordan's arrow moving?
Yes, yes. No,
that's C2. Let's go down. 3, 4, 5, and show us the beak on 5. Look at that. That's called DISH, D-I-S-H, diffuse idiopathic skeletal hyperostosis. And then 6, and then 7, and T1. So we're starting with the 6-7. I believe we can get the 7-1. That's why I'm going to start the surgery. I wanted to make sure I felt comfortable getting down there, and I say we have a very good chance of making it to 7-1. All right, so we're going to start with the discogram and shot. Now, show us the tear in the back of the disc at C6-7. There's the tear, that black line, and that is literally where the herniation came out of, through that tear. It's a tear in the annulus fibrosus. The annulus is the wall that is circumferential around the disc, and it basically keeps the nuclear material in place, the nuclear material being the nucleus pulposus. Okay, so we're at C6-7. I'm going to make my incision. I've already given some local. The local includes epinephrine, lidocaine, and marcaine. So the lidocaine and marcaine are local painkillers, so she doesn't feel any discomfort and have a cardiovascular response. She is intubated under general endotracheal anesthesia. The epinephrine is going to narrow small blood vessels so that there's no skin bleeding, or minimize skin bleeding, I should say. There's no way to prevent bleeding, period, altogether. I'm making a 4mm incision with a number 11 blade, 4 millimeters. Can you guys see the incision?
I think there's a light blocking the camera view, but...
Oh yeah, you guys cannot have this light here. No, pull it the other way.
Perfect, perfect. We see it now.
Turn the light so it's here, please. Yeah, is it out of the way?
Yep, perfect.
All right, we made our incision. Now we're going to take our needle out, leaving the guide wire in place. Okay, so we're going to use this dilator, and people ask me this all the time. How do you not damage the disc as you pass through it? Well, if you look carefully at the tip of this is specially designed not to damage the disc. It spreads fibers, okay? It spreads tissue fibers. The only thing it can't spread is the skin. So that's why we have to make an incision in the skin. The skin is not spreadable. It has to be cut. All right, so here we go. We're going down. Shot. You can see on the x-ray, let's show everybody some of the anatomy, okay? Let's show everybody some of the anatomy. Bring your arrow. Let's show everybody the 6 and 7 bones. Yep, 6 and now 7 down there. Don't move the arrow too much, it's confusing. And then show the 6-7 disc space. You can see the die is almost out. Show the tip of the dilator at the front of the disc. Yes. Now show us the temperature probe within the esophagus. Yes, the braided thing is the temperature probe in the esophagus. Okay? And show us the endotracheal tube. Good. Very good. So that's the endotracheal tube. Let's go and do an AP view really quick. We're going to make sure the tip of the dilator is in the midline of the spine. You want to be as centered as possible, but you don't want to be off of what's called the ALL. You don't want to be in what's called the, there it is, very nice. So you can see the tip of the dilator is just to the right of midline. It's really nice. And the guide wire heads off to the right foramen at C6-7. So the longest coli muscles sit in front of the spine. You don't want to be through them. So we're just to the side of midline, to the right side, and that's where her herniation is. Now, there is another surgeon in the United States that does what's called a, so 2, 3, 4, 5, 6, 7, who does a approach off to the side of the disc where he goes through the uncinate process. We don't do that. I don't like drilling out the uncinate process. There's no reason to do that. We're just going transdiscal. Transdiscal is a better, safer approach. It doesn't destabilize the spine in any way. All right, so we're off on orbit just a little bit. Can you get us corrected on orbit? Because the spine is rotated a bit. There's some scoliosis. The other direction, maybe? Let's try that. All right, that, I don't know. That's maybe worse. Let's try a little bit of correction the other way. It's about 1.5 degrees off. I guess that's probably the best we're going to get right there. Yeah. It's still off a little bit, but. All right. We're now at the back of the 6-7 disc, right where the herniation is, okay? With the tip of the dilator. Let's show an AP view. And remember, I'm aiming for that right foramen. So I start on the opposite side of the neck and aim for the right foramen. Perfect. Very nice. And you guys see how the esophagus is moved over? Show them the esophagus. So we're not going through the esophagus, we're going besides it. There you go. Perfect. So the Duke laser disc repair, which is what you're watching, was created at Duke Spine Institute here in Florida, United States. And it's a unique surgery that not only do we do a discectomy, we also do we don't do a discectomy, we do a herniectomy, which means removing the hernia, okay? We don't take the disc out. So we're doing a herniectomy and an annular debridement, okay? Annular debridement. And the annular debridement is really quite unique. There's other surgeons who have done herniectomies before, but an annular debridement is using a laser to clean the annulus fibrosus, which was torn, to allow the herniation through. Unfortunately, most surgeons don't understand this stuff. So they just do fusions and artificial discs, like cavemen, right? We're more like a sniper. We're going to take out a specific target. They're more like a caveman walking around with a club, doing fusions and artificial discs. I used to be one of those cavemen a long time ago, and then I was transformed. And it all began with seeing my first endoscopic surgery like this done by the Koreans. And they did a discectomy. I've changed the technique. What's going on? All right. Can you guys see the incision here? Basically, it's a bloodless surgery. You see this, Henry?
Yes, we do.
There's no bleeding. That's a 4mm incision. Henry, get some good views of this because I want to potentially put this case as well into our database for talks and for, I'm definitely going to want preoperative MRI pictures on this one. And I'm going to want the intraoperative video, okay? This is an important educational one.
Copy that.
Because we don't do a lot of C6-T1. All right, now I'm going to advance the tube to where the tip of the dilator is. I need distraction, shoulder pull, and here we go. Shot. She's very collapsed. Luis, your job is to keep an eye on the tip. Make sure the tip doesn't advance. Shot. Now, folks, if you're wondering why is it so hard to advance this tube, because this is a degenerative disc disease. We're done. Nice job, everyone. Degenerative disc disease comes from a herniation that is essentially neglected for a long time, and over time, inflammation destroys the disc space. Unfortunately, 99.999% of doctors don't know that. They don't know what causes degenerative disc disease. They're still searching, but we do at Duke Spine. We figured it out. It's inflammation. Over time, inflammation destroys the nucleus and causes erosions of the end plates and sclerosis and all the modic changes that we see. But I've tried teaching other doctors about this, but they just don't listen. And, 20 years from now, everyone's going to know it's from inflammation. But unfortunately, they're very slow to assimilate new knowledge. It's mostly because of arrogance and ignorance, which I can't fix, folks. I wish there was a surgery for arrogance and ignorance, because they all basically need it. Anyway, here we are. We're going to go down 6-7. And at the bottom here is the herniation. There it is. You guys see it? Now remember, 6-7 is smaller than C7-T1. That's the big one. That's the big soft one that we need to get next. That's going to be a very challenging one. One of the few in my career where I've actually gone to C7-T1. There's the herniation right there. You guys see it? It's blue and it's wiggling around. The laser is jiggling it and wiggling it. We're going to go in and grab it out because the laser sometimes is needed to release the nucleus pulposus herniation from the annular tear where it's stuck to. There we go. That's one piece out. We've talked about this before, folks. Herniations are not a one-time event. They're a multiple event over time. And every time you reherniate, a new piece of disc material or nucleus comes out of the tear. What happens is it creates more inflammation and pain. And that's why people get arm pain when it's in their neck. That's why they get neck pain, arm pain, headaches. We call the headaches cervicogenic headaches. Now you see we use the grabber. Look how ineffective the grabber was. Okay? It got a little piece, but it left a lot there. So that's why we don't use the grabber. These surgeries don't work when you just use the grabber. The laser is essential, but we're the first to use the laser in this way to debride the annular tear. That's why this is a Duke Spine original surgery. It was created at Duke Spine Institute here in Florida by Dr. Ara Duke-Majan, the founder. Yes, that's me. And I think we're overexposed on the camera. My fiber keeps moving back. All right, so I'm trying to lock my fiber in place. That's good. You guys see this is all herniation. A little bit of bone spur there. And we're getting close to what's called the posterior longitudinal ligament. You can start to see the fibers. Now, I cannot move this very much right now because this disc is so collapsed. But you're going to see, by the time I'm done fixing C6-7, you're going to start to see things moving. So in other words, this surgery restores movement to the disc. It's the only surgery in the world that actually restores movement to the disc. Artificial disc, that's a bone spur, by the way, right there. Artificial discs proclaim to preserve movement compared to fusion, which they do sometimes, but they've done studies that now show the artificial discs don't really work to preserve movement. But this surgery, folks, you're going to see movement where there is no movement currently. So when I go in, there's no movement. Okay, I'm trying to move the tube. I cannot get the bones to move at all. But when I'm done, and we do this all the time, you're going to start to see some movement as I start to move and use the laser to release the scar tissue. It's a scar tissue that's holding things in place. So I'm going to keep going back and forth. I'm going to have to reposition my laser again. And the laser just keeps slipping backwards. You guys see the laser fiber?
Yes, we do. We have a couple questions as well.
Yeah, sure.
This first one comes from Edward on YouTube.
Uh-huh.
And they ask, in the beginning portion of the procedure for cervical spine procedures, the patient is asleep, unlike the lumbar surgery?
Correct. That is correct, Edward. Patient is asleep. There's another piece of herniation, and I'm going to float it out. Yes, so for cervical Duke laser disc repair, patients are intubated under general endotracheal anesthesia. For lumbar, they're awake. Two totally different types of surgery in terms of how the patients are treated at the beginning. These are bone spurs right here. See how the laser just melts them? On the other hand, for thoracic as well, the patients are awake. So lumbar and thoracic, endoscopic, patients are awake in the beginning and then put to sleep. For cervical, they stay asleep the whole surgery. Okay? Great observation. You've been doing your homework, Edward. Again, the whole surgery is being done with a 4mm incision. This is all part of the herniation here that we're trying to remove. A little bit of this material on the end there. These are bone spurs here, melting away with the laser. I get a lot of questions about bone spurs. The laser can remove bone spurs. Starting to see some more movement of the tube as I'm trying to head out the foramen and get the herniation out in the foramen. All right, so I'm going to pull back just a little on the tube and expose more of the herniation to the side. All that is herniated disc osteophyte, what they call disc osteophyte. All right. So far, so good. Now, I told this patient and her husband there's about a 20% chance that I cannot get to both discs, especially the one I'm worried about is the C7-T1, the next one. And there still is a chance I cannot reach it. But before I started, I looked at the x-rays in the operating room. I pulled on her shoulders. We held her neck in traction, inline traction, and slight extension, and we were able to see C7-T1. So I decided, yes, I think we can do this. I feel good about it. But there's always a chance that during the surgery, I cannot complete a surgery. And that's a chance for any surgery. It's not common. It's very rare. But it happens when you have unusual situations like this patient. This is a giant herniation. Look at this thing. It's just, see all the gold? It's calcified. So that's calcified herniation. It's not solidly calcified. It's not a rock, but it's on its way to becoming a rock. And, oh yeah, come on out. There we go. And we just basically use the laser to break it into little pieces, releasing those pieces. You see that okay?
Yes, we do.
So Henry, we'll take some more questions in a minute, but let's start by showing our audience a video on how do herniated discs actually cause neck pain and arm pain and even headaches in some patients.
Traumatic injury on the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissue develops within the annular tear, causing neck pain. The inflamed annular tear generates pain signals. Additional injuries can cause worsening symptoms. Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain. Pain signals travel up the nerves to the brain, causing localized neck pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of neck pain. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.dukespine.com.
Welcome back. All right, so this is again C6-7, and I'm going foramen to foramen with my tube, and I'm windshield wiping it side to side, okay? And I'm able to get these bone spurs here, as well as the herniation. Remember when we started, the window was full of herniation. It's all gone now. And that's the back of the disc right there. That's basically the PLL and maybe a little bit of residual material and scar, basically scar tissue from the chronic inflammation, okay? And so I've gone back and forth, and we've taken a disc that's essentially immobile because of degenerative changes to the disc, and we've probably given it maybe half a degree of movement, okay? But unlike fusion, pull this down. Unlike fusion, and I need your fingers not to take the place of the chest. Fusion, you know, you're definitely losing movement. There's no doubt about it. It's 100% gonna happen. So with laser surgery, you're not losing any movement. You may gain a little bit of movement. How's our irrigation? So I am virtually at my limit here getting a lateral because of her chest is obstructing me. And there's still another herniation right there, a pretty big one. You can see it. But I'm having some difficulty getting my tube over to the corner where the herniation is. You gotta pull like that, Luis. Come on. Better? Yeah, I mean, it's difficult because her anatomy is making it virtually impossible to get further to the side, but that looks pretty good. We've done a pretty good job. Let's go back across. All right, what other questions can we answer for our audience?
Yes, we have a question from Lubisa on Facebook.
Great.
And they ask, good day. In which case of disc injury do you suggest fusion or union LP?
I don't recommend fusion for any disc problems, okay? We used to do fusions on all of them. I've done 1,000 anterior cervical decompression and fusions, 1,000 patients in my career, okay? So I have a lot of experience doing it, certainly in the top 10% of spine surgeons in terms of fusions. And being a fusion surgeon myself, you can watch some of our fusion videos on our YouTube channel. I don't recommend it for anything. If you take all disc problems that need surgery, that other surgeons say fusion, 99% of them we can treat with a laser. There's going to be a small handful because of anatomy we're not going to be able to get to and treat. But virtually every single surgery that says fusion, we can do with laser. All right? There's another herniation, lots of them. That's a big one. See how smooth it is? That smoothness comes from inflammation and scarring of the surface of that herniation. Herniations are normally jagged. Wait, let's show the audience. Put the light on. I'll show you this little herniation here. It looks big, right? But look how big it really is. Can you see it?
Yes, we can.
Where's the millimeter marker? Here. Put it down. Oh, we don't have millimeter? Those are inches. Those are inches. Yeah, there we go. All right. So, here you go. You guys see it? Don't move.
Yes, we do.
Here's the herniation. It's around, to me, it looks like it's around 5 millimeters long, and it's around 3 millimeters wide. You guys see that?
Yes, we do.
All right. And here's your tube. Here's your endoscope, and there's the laser. So that just gives you a reference. You guys see how big the laser is relative to the herniation? Okay? Pretty cool. Anyway, this is the most advanced surgery in the world for a herniated or bulging disc or even a degenerated disc. And this patient found us. Her and her husband made the decision. And yeah, I've done 1,000 ACDFs, but in that 1,000 ACDFs, I have done 2.5 discs per ACDF. So if you really want to know, technically I've done 2,500 disc removals and fusions in 1,000 patients. Does that make sense? So I'm very experienced with fusion, ACDF. That's a bone spur right there. I'm removing a calcified piece of disc right there. Look at that shriveling up with the laser. Laser is so powerful. Remember, none of this could be done without the laser. If you try to use any other tool in the world, it is dangerous because you're going to use, like, say, a drill bit. You're going to stick it down there and go blind in somebody's spinal cord. You'll paralyze them. So the only tool that can be used with such precision is the laser. And this is the best of the lasers right here. It's called the Homium YAG medical grade laser. It's all FDA approved for spine. And this patient literally is getting the best surgery in the world for her problem. The only concern I have is, can I reach it? Can I reach the next disc? That's my biggest concern. This one we got to, no problem. It is, I mean, I shouldn't say no problem. It's a collapsed disc. So it was hard to do. We had to pull on the shoulders a little to distract the disc open a little, but we got it done, no problem. The next one is going to be the bigger concern, and that is the C6-T1. We don't know if we're going to be able to get it yet, but we think we can. Otherwise, I wouldn't have done the surgery. All right, that's all scar tissue. There's no more herniation down there. So I'm going to just go for another minute here, and then I'm going to go for C6-T1. All right, what other questions can we answer?
We have a question from Miran on Facebook,
Yeah, Miran, go ahead.
and they asked, surgery on multiple levels, which one would be operated first, cervical or lumbar?
Yeah, great question. We get that a lot. Which do you recommend first, cervical or lumbar? It doesn't really matter. I prefer cervical first if you give me the choice. So if somebody comes here, they need cervical and lumbar, they're going to fly in. We're going to do the cervical on Tuesday, the lumbar on Thursday, and they just spend a week here. All right, this is the last of the herniation here. It's out in the right foramen, and those are all bone spurs, by the way. I'm right there that I'm melting away are bone spurs. I'm melting them away literally. Folks, you see the fiber right there, that glass fiber? That's 0.5 millimeter wide, right, Luis?
Yes.
And so if that's 0.5 millimeter, okay, remember the millimeter? That herniation was 5 millimeters. That's 0.5 millimeter. So the precision of this laser is about 1/10 of a millimeter. That is 100 micrometers. So it's the most precise tool that can be used around the spinal cord and nerves. Folks, unfortunately, 99.999% of spine surgeons have no clue how to do this kind of surgery. They've never been trained. This is advanced for them. And I'm talking about the most advanced spine surgeons. I just went to a meeting with the most advanced spine surgeons in the United States, in Utah. There was this Congress of Neurological Surgeons spine complication course. And you should see the complications. These guys, the best surgeons in the United States, UC San Francisco, University of Utah, Miami, all of them, Hopkins, Columbia, they're there showing their complications. They came to me and said, "Do you have any complications to show?" And I said, "Unfortunately, I don't, because we don't have complications," okay? And I say that because it's true. We've not had a single complication with this surgery in 16 years. Now, hey guys, I have water on the floor. I need a towel here. Have we ever had to abort this surgery? Yes. And I've had to abort about probably 3 of these, maybe 4 out of 600 cervicals. I've had to abort probably the same number of lumbars. So the chance of getting an aborted case is about 0.5%. And we abort them because we can't get to the disc herniation because of the patient's anatomy. So I don't consider an aborted surgery or aborted level as a complication. I don't know anybody that would. Hey, you got a herniation here? Did you mean to throw that away? Okay. And I think if I did not abort the surgeries that I did, I would have had, more irrigation. I would have had a complication. So you abort doing something that you can't do safely because of safety. You don't want to give the patient a complication. Unfortunately, most spine surgeons, hey, I need it here. Most spine surgeons think complications are okay. If you talk to them, they'll tell you, yeah, we can get a complication, we've had them. And truthfully, I've spoken to them, they just think it's normal. I don't think it's normal to have a complication. I would not want a complication myself. Therefore, I would never give my patient a complication. And I do everything I can to avoid it. And that's why we have to abort sometimes a level or a case, because we can't safely get to it. All right, so at this point we've finished 6-7, and now I'm going to go to the 7-T1, okay? This is a C7-T1 herniation. Is there any way to show them how big this herniation is, Henry, on the MRI? Because I don't know if the MRI in the bottom corner shows it that well.
I don't believe so at the moment. I'm sorry.
That's fine. All right. Well, here we are, folks. The moment of truth. Can we reach C7-T1 from the front? And I'm going to do everything we can within our power to do so. First step to relocate our equipment to the next disc, which you can see it down there, and go ahead and show them C7-T1, Jordan. Yep, right there. See that white line? And right there is the entry point. And I believe we can get this safely, so I'm going to give it a try. All right? You can see we've not lost any blood. This is basically a bloodless surgery. The first step is to take out my tube and leave my dilator. So that's step number 1. Here we go. I'm going to wiggle my tube off, shot. I'm leaving my dilator there. I felt it come out of the disc right there. I just felt it, perfect. And Luis, your job is to watch the tip of the dilator and make sure the tip doesn't advance, okay? That's your only job. Let me do the rest. Shot. Okay, perfect. All right, guys, see this? What are you watching, Henry? Here you go. You watching this?
Yes, sir.
All right, now take a look. Look at that. There's the incision, 4 millimeters, guys. You see it?
Yes, we do.
How would you like to have 2 of your discs fixed with a 4 millimeter incision? Look at this thing. Can you guys see the metric? 4 millimeters.
Yes, we do.
4 millimeters. All right, here we go. Everybody ready for the big move? So here's what's going to happen. We're going to do everything we're supposed to do, shoulders, neck. I'm going to move this thing out, and then I'm going to need a quick AP at some point to make sure we're midline as I move down south along the ALL. Shot? All right, that's perfect, guys. Oh my gosh, I love you. You guys are awesome. Shot. I have the best team in the world. Here we go, coming out. And this is all feel. Out. Shot. Good. AP, I want to make sure I'm in the midline. I don't want to get off the middle. That's very important. You check yourself. And by the way, this technique of moving from one disc to the other, the Koreans are not the first to do it. We are the first at Duke Spine. First in the world to do this. And this is not the first time we've done it. Obviously, we've been doing it for 16 years. So there's a technique. Shot. All right, I need an AP. So I'm moving down towards the next disc. Feels like I'm off to the side a little bit. So So I need to figure out where we are. Shot. Oh yeah, we're way off. So we need to come back. Shot. No, stay there. All right, back in the midline. Now let's go back down to 7-1. That's why you have to check AP and lateral. See the esophagus bending around? You cannot let the esophagus get underneath your tip. You cannot lift your tip. That is against the rules. There we go. We're over the disc right there. Shot? Oh, yeah. Perfect. Wait. 2, 3, 4, 5, 6, 7, T1, huh? Everyone agree? AP? I feel like I'm off again. I want to check my AP. Quick AP. I'm going to need to see 2 again in a moment. Shot. Quick, quick. Oh my God, we're in the midline. It's perfect. And now let's go lateral again. I just need to see C2 to verify we're at the right disc. Quick, quick. Show me 2. Just move up a micron. There's C2, 3, 4, 5, 6, 7, T1. Everyone agree? Okay. Perfect. Here we go. I need the mallet. We're in the midline, right? Everyone agree? We saw that. Here we go through the anterior ALL and the anterior, what do you call it? Annulus. Sorry, I'm just a little focused. All right, give me an AP. It's perfect. My God. This literally is the first in the world ever done. A C7-T1 anteriorly, endoscopically. Beautiful. Henry, this has to be labeled in a special folder, like I've asked you to do the other ones, and it's going to be C7-T1.
Copy that.
Cervical DLDR, anterior. I think the first of its kind ever done, because it's so rare to have a 7-1 herniation. Take. Okay. I'm going to pipe clean with the guide wire. I'm just going to clean the disc material if there is any. Oh yeah, beautiful. All right, here we go with the discogram, because we still need to do our discogram. It's good to know it. I can still get in the hole. Shot. Perfect. Shot. All right, there it is. You guys see the blush coming out? It's one more shot. All right, yeah. So I've injected dye. Show us the tear in the back of the disc. You guys see the arrow? That's the tear. Show the giant herniation there. Woo, yeah, no. No, it's that looks like a kidney. Right at the, no. Yes, that's it. Now do the shape. Yes, that's it. That's the herniation, folks. Actually, let's do a little more dye. See if we can make the herniation stand out a little more, okay? Almost done. Nope. All right, Jordan. I just injected. Shot. Yeah, one more shot. All right, that's the herniation there. You guys see it? The dye is outlining it. That's beautiful. All right, at this point, I'm going to advance my dilator further. Shot. There we go. And remember, this, as opposed to the last one, this is a soft disc herniation. Soft disc herniation compared to the last one, which was primarily degenerative disc. This is a soft herniation. Bear with me just a few more minutes. Shot. I'm checking my dilator. It pushed back just a little bit there, but I'm okay with the position. If you're wondering what the blue stuff is, I'm not bleeding. That is our Duke Spine special dye. It stains the degenerated nuclear material, and it shows me basically where are the herniation fragments. It will not stain anything else but nucleus pulposus. So it's the most incredible dye in the world. I'm not the first to use it. I was taught to use it. I'll tell you the things that I was the first to do, and this is the first in the world, C7-T1, anterior approach, transdiscal endoscopic, laser assisted. This is the first. Now, show us just for a second. This is kind of cool. Go just literally quarter of an inch north, and I want to show C2 so everyone can see C2. Shot? Is that it right there? Okay, beautiful. You can see C2, 3, 4, 5, 6, 7, 1. Perfect. All right, I'm going to advance my tube through the disc. Watch the dilator tip, Luis. I need shot. Okay? So the tube that we're going to do the surgery through slides along the dilator. I'm so happy we're going to get this done. I had so much worry for this patient that we wouldn't reach. See that? The dilator popped back. So I got to go in and put it back. Okay? Otherwise, you're just doing a biopsy. We're not interested in a biopsy. Okay? That's how you do biopsies. You just send a tube down that's hollow in the middle, and it literally core biopsies tissue. We're not interested in a biopsy. We want to remove just the herniation itself, shot. So what do you call removal of a herniation? You call it a herniectomy. Okay? Believe it or not, it's called a herniectomy. And for years, shot? Why is it pushing back, by the way? Anybody know? Who's been watching my videos? It's pushing back because of pressure being put on the tip. What's causing the pressure? Inflammation. Shot? We've seen this many times before. I just need one more whack and we're there. All right. Should be good. It's perfect. You can see, show us the tip of this endoscopic tube. You see it's at the back of the disc. Show us the back of C7. Yeah, no, right there. Yeah, that's the back of the bone. That's the end of the disc is normally where the tube is. So we're there for the herniation. Here we go. I want to show you this, Henry. Don't push down whatever you do. Did you push down? No. All right. You guys see this? This is all the blood loss from the whole surgery right there. It's literally 1, 2, 3, maybe 5 drops of blood. The blue stuff is not her blood, by the way. In case you're wondering, she's not part alien. All right, this is magnificent. Henry, let's get the lights on. Henry, I want a nice shot of the neck, C6-T1. Okay, and I need a marking pen. Can you guys see this, Henry?
Yes, we do.
This is C7-T1. Okay, C7-T1. Right there, 4 millimeters. Beautiful.
Got it.
Thank you. And keep a still image. Again, you're seeing history made. Most herniations are 5, 6, 6, 7, 4, 5 in that order, but C7-T1 is rare. And again, you have to have a long neck normally to have a C7-T1 herniation. She does. All right, there's your herniation. Like I said last time, it's going to look different than the last one because this is a fresh herniation. Okay? And the last herniation was, C7-T1 was an old degeneration, an old one. She just let it go over the years and it just destroyed the disc. It's not her fault. I'm sure she didn't find the right doctor. Doctors are the worst advocates for good patient care, I've found. So many doctors tell patients the wrong thing. Patients listen, believing those doctors, and they're doing the wrong treatment. Whether the doctor tells them there's no fix for your pain, or the doctor tells them, let's get a quick light on and shot. This is the first piece of herniation that came out at this disc. You guys see it?
Yes, we do.
You see what I mean? That get a nice snap of that still. The herniation stains blue because it's acidic. Not Hasidic like a Hasidic Jew, acidic. Acid like acid base, pH is low, proton concentration is high. Anyway, doctors tell patients, oh, your pain can't be cured. You have to learn to live with it. That's a lie. Doctors tell patients, oh, you have to have a fusion. That's a lie. You don't have to have a fusion. That's only because your doctor doesn't know how to do advanced spine surgery. Or your doctor tells you you need an artificial disc. That's a lie. Again, that's only because they don't know advanced spine surgery. Okay? And I have people, I laugh at them online. Well, my doctor's at Harvard or my doctor's at Hopkins. I don't care. Your doctor's behind the time about 30 years. Okay? So get over it. Just because a doctor's at Harvard or Hopkins doesn't mean they're a better doctor. It just means that maybe they were friends with somebody or they're willing to work for peanuts. I don't know. But somehow they're compromised, I could tell you that. There's a lot of reasons doctors are at Harvard or Hopkins. And it's very rarely because of merits of their hard work. It's usually something to do with someone's greasing someone's palms. Money is being exchanged off of the patient's backs. Yeah, I like that. Off of the patient's backs and necks. You patients, you're guinea pigs. You're basically sheep. And they're hurting you to do what they want, which is to put metal in you. Don't let them do it. Anyway, we were at this conference in Utah this weekend, and how many complications did I see? Just silly stuff that never should have been. Like, if I showed you those complications, you would cry. People dying from stupid mistakes the surgeons make, doing all these instrumented surgeries with fusions that fail. I mean, literally, a surgery that I would do at L45 with a laser and take 30 minutes, the patient would walk out. They're doing a fusion from L2 to sacrum with screws and rods at every level and cages at every level. Okay? And it's like, why? And they're not even thinking about why did they do it. They're thinking about, how do I prevent the complication? Well, how you prevent the complication, which is the broken screws and rods, is to not put them there in the first place. Okay? Don't do the fusion for degenerative conditions that can be fixed endoscopically. But they don't want to hear that, you know. And of course, the whole conference is sponsored by the companies that sell the screws and rods. And it's just one big, you know, it's just a way for a lot of these surgeons that do tremendous amount of screw and rod surgeries, metal surgeries, to get together and kind of, I don't know, what do you call it, a pity party? You know, and actually the worst thing about it is they're bragging about how they handle the complications. In other words, hey, look at the new screws and rods that I put in, even bigger than the last ones. Yeah, the patient's paralyzed, but as a result of my surgery, but you know what? That's okay because now their x-rays look good, even though they can't walk anymore. How many paralyzed people did I see in that conference as complications of stupidity from these top surgeons that are running the university training programs, okay? Literally running the university training program. I'm going to just say this. The #1 ranked neurosurgery program right now in the United States is UC San Francisco. They were there, the top surgeons. I'm not going to mention names. Of course, they all had money they were getting from the companies that make the screws and rods, lots of money. They call it a disclosure, and you could see the disclosures. Some doctors would literally have 10 different company disclosures they're working for, getting millions of dollars to put in screws and rods, okay? That's you folks out there getting those screws and rods put in your spines to make them rich. And you guys are the ones who have to live with the being paralyzed from the surgery, failing. Okay, and I saw it. I saw the complications with my own eyes. And they disgust me. Why? Because I don't think it's right what they're doing, to use people to make millions of dollars in profit by putting metal in them. And you guys all think your surgeons are just looking after your best interest. You're wrong. By the way, these are all herniations here. So we're getting all the herniations out endoscopically without putting a single piece of metal in this patient's body. And, you know, honestly, compared to the surgeries that I've seen, this is a bargain, cost-wise, for the patient. I know it's a lot of money for people, but it's a bargain because the quality of life improvement that this patient will have and not have to have a complication from some major metal-based surgery is amazing. These are all pieces of herniation, by the way. See them coming up? Every one of them is a single independent herniation. And so far we've taken out, what, 8, 10 that floated out or pulled out, right? If you go back and start counting. All right, so have we shown the video on how the Duke laser disc repair works in the neck?
We have not, no.
Let's do that, and then we're going to take some questions. Laser.
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.dukespine.com.
So anyway, thank you for watching, and hopefully the educational video. There's another herniation. Like I said, each of these balls coming out is a single herniation. And notice how it takes up the whole tube. They're all about 3 millimeters, 4 millimeters, right? They're not giant. Watch your mask. They're not, everyone thinks of a herniation as being one giant piece of herniation. It's not. It's actually many pieces. And you can see that here. Every one of these is a herniation. Maybe someday I'll have a fellow who'll go back and look at all these videos and estimate the size of these herniations. Now, I have to say, there was some intelligence at this meeting, just the smallest glimmer, when I talked about endoscopic surgery to these metal magistrates, okay? These surgeons, these are the professors of neurosurgery and orthopedics at the meeting. These are the heads of training programs in spine in the United States. These are the people who make the decisions of what surgeries should be done. And more importantly, what metal we'll use, what company's metal we're going to use, okay? And there was one little glimmer of hope there. And it was actually a fellow who came up to me after my many comments of endoscopic surgery. She is the fellow at the University of Utah. And she said, I want to learn endoscopic surgery, but I can't find anywhere to learn. And I said, yeah, that's because it's being blocked by the companies that your boss, your chairman of spine surgery, is blocking you from learning, because they want you to go out and put metal in people. Okay, that's the whole point. They're culturing you to do the same thing. They're grooming you, okay? And she understands that. And she doesn't want to do metal. She wants to learn endoscopic. So the only intelligent person there, in my opinion, was her. See how the herniation right there is stuck to the tear. That's why we call this a debridement, because we're quite literally debriding. Bone spur, gone. We're quite literally debriding. Look at all these herniations. It's incredible. Non-stop, right? I've got to get that piece out right there so that I can get the deeper ones out. Great, so let's go to questions.
Alrighty, we have our first question comes from Miran once more on Facebook.
Yes.
And they said, in a patient with a collapsed cervical disc, who does the regular tractions to the neck, who does regular tractions to the neck? Would that better prepare for the surgery, being less challenging to get to the disc? When I do tractions, I get more movement in the disc and helps pain loosening muscles.
Yeah, Miran, that's a great point. No one's ever asked that before, and I've never thought about it. So yes, in the operating room, when we want to get into a collapsed disc with the endoscope, we do actually put traction on the patient's neck. It's manual traction. It's done by our anesthesiologist, and it's done very gently, but it's also done, you have to understand, we're doing it under anesthesia, which means the patient's asleep. So the muscles themselves are not tight. We also give muscle relaxer. So the muscles are actually relaxed. You understand? This is a giant herniation sitting in the spinal cord right here. Just so you know, that's sitting in the spinal cord. And I'm taking it out of the spinal cord 0.5 millimeter at a time. Incredible. I'm just peeling it out, 0.5 millimeter at a time. This is where the Koreans get into trouble. The people who taught me the basics of the technique, their patients are awake and moving around. And when you're moving around right now, all you have to do is move a little bit. Literally, you could see 0.5 millimeter of movement, and you're going to go into the spinal cord with the laser. And that's going to create a lot of problems. Okay, so I don't keep my patients awake. You guys see how the spinal cord right there, that's literally the spinal cord, and this herniation is sitting inside her spinal cord. Like not through the dura, but on the dura. And I'm literally peeling it bit by bit. Now, how come this herniation is sitting on the spinal cord? Because it went through what's called the posterior longitudinal ligament. And it's in the epidural space, and it's literally sitting in front of the dura. Okay. Huge herniation, huge. This is a beast. It's like debulking a tumor, to be quite honest. It's not a tumor, it's a herniation. But tumor in Latin just means mass. So we're removing a mass. And this is digging into her spinal cord and her nerves. This is the main reason we're here. And look how scarred it is. It's already calcifying inside. Look at that gold color, right? This is the most precise surgery, neurosurgery in the world, right here, okay? Why? Because neurosurgery uses a microscope when it wants to be precise. This is more than a microscope. This is more resolution, more detail than even a microscope will give you. I use a microscope all the time. We have them here. I use them for ACDF, right? I use them for brain tumors, things like that. Not here. I don't take brain tumors out here. But I'm very used to using a microscope. I was trained at UF in Gainesville with Dr. Albert Roten. He was one of the first to use a microscope for brain tumor surgery, okay? And we used them every day when I was training for 7 years, every day. So I'm very good with a microscope, but endoscopic surgery is the next level. And look at that. There's the spinal cord right there. You guys see the spinal cord? Right there. And look how this herniation was digging into it. And I'm literally peeling it off 0.5 millimeter at a time. And if you don't use the laser, it ain't happening, ever. This is, and people criticize the laser, these surgeons that don't use it because they have no clue what they're doing. That's how stupid they are. And I spent the whole weekend with them in Utah on a spine complication course. They are dumb. They're so dumb. And they're so selfish. Honestly, I don't like them at all. They don't like me. Why? Because I'm doing new things and I'm not putting metal. And so they're like a big circle jerk over there, just jerking each other off with metal. And the companies are sponsoring it and they're taking them out for drinks and steak dinners. Nobody invited me out for a drink or a steak dinner. Nobody. Why? Because I don't put metal in. I'm not on the take. I'm not part of their culture. I'm not part of their group. The person who invited me is the director of the course, as a matter of fact, the head of the course, the head of spine surgery at Shands Hospital in Gainesville, UF. He personally invited me to come, and you have to be invited, by the way, but he knew about my endoscopic stuff, and he wanted me to come. Of course, I trained at UF, which was at the time the top neurosurgery program in the world, and of course, it's not the same anymore. Woo! This has taken a while, but you can see why. I need something here if you can, just a little bit.
Yes, sir.
I don't know, maybe your hand's in my way. I gotta have you move it.
You want to switch the irrigation to the other side?
Switch the irrigation to the other side. That is brilliant. I love it, absolutely. Will it help?
I believe.
Yeah, then we need to. Guys, I'm almost done here. 5 minutes, Dr. Berndes. You all see the spinal cord right there? Look at it, it's totally decompressed. That is the spinal cord, that's the dura. Okay, we're gonna switch the irrigation to the other side. Well, let me think. No, because I have to come back the other way. All right, so let's just move our laser forward a little bit. And we're ready for questions.
Alrighty, our
5
next,
minutes, we're totally done. Is that everything?
Well, maybe 8 minutes.
Our next question, I don't believe it's a question, it's just either seeking for help or advice. This comes from Sharaf on YouTube.
Hello, Sharaf.
And they said, good morning. I'm scheduled for Zoom on February 3rd for my back. I have a CT scan today for my neck after C5 through C6 ACDF done on October of 2021. After 6 months, had revision done on May of 2022 because screws bolt out from C6
Yes.
and doctor had to add spacers in my facet joints after
Jesus.
revision had. Clicking when I lean my head to the left and headaches all the time in cold weather
I'm so sorry to hear that.
start after the first surgery.
Yeah.
I live in Indiana, Canada, or Indiana. We discussed that on February 3rd. I'll submit my CT scan image to Duke Spine MRI.
Yes, we can help you. We can help you. I don't know what you're going to need, obviously, yes. And just as a general comment for everybody, doctors cannot make proper surgery decisions or any treatment decisions at all, whether it's surgery or whatever, unless we have certain information. That information includes the MRI images and the report, both, as well as history from the patient. Important there, look at that herniation. And it's coming out right there. You guys see that? Bubbling up out of the epidural space. So we need the history, we need a physical, which we do by Zoom, and we need the actual MRI images and the report. Those things, folks, those things. Once we have them, we can tell you what's wrong. Oh, look at that herniation. That is so cool. It came out of the foramen. Oh, yes. Wondrous. Look how scarred up it is, how calcified it is with the gold, how white and scarred it is. Notice it didn't stain blue because it's got all scarred. This is all scarred. So this herniation at 7-1 is an old one, this part of it. There's new parts too, which are blue, very dark blue, okay? Old stuff like scar tissue doesn't stain blue. This is an old, oh, look at that. Incredible, I love this surgery. I used to love doing fusions because it helped people if you do it right, and I did it right, but this endoscopic stuff is the bomb. It is the bomb. It is the bomb. It's just so hard for me to go to meetings and watch our top spine surgeons at the universities teaching their residents just how to put metal in. All condoned by the implant companies, all supported and promoted by these companies that make billions of dollars off of selling metal in the United States alone. And I had a comment from somebody on YouTube from India, and they said, my God, they watched one of my videos talking about how the screws cost $1,000. I got to pull that out with a grabber. And they said in India, the screws are $100 or $50. The cages are, the plates are $100, and the cages are $200. Here, the cages are $5,000 list price. We get a good discount because I used to do a lot of fusion volume. So when we do a fusion, we don't pay as much. But wow, I mean, we're getting ripped off as a society. We're just so stupid. Our government should intervene, in my opinion, and make the Duke laser disc repair the procedure that everybody has to do. There's the dura. Folks, this is beautiful. That's the spinal cord right there. And look how that herniation was sitting there causing inflammation on the spinal cord. You understand? I mean, it was digging in. And now we've got rid of it. We still have a little bit here. I'm going to get, and I will need to switch the irrigation. Let's switch the irrigation. Hold on. Just give me a second. We're going to switch the irrigation to the other side. Thanks, Luis. So this way I can actually get a little closer to her chest because her chest is blocking me right now. It's keeping me from getting to certain spots, okay? Because remember, C7-T1, normally we don't do it. Can you bring my pedal closer, please? There's the dura. There's the last of the herniation right there. Is the irrigation going? Yeah? Good. All right, so we're right at getting to the limit of our laser and our tube. All right, beautiful. Right there. I'm going to pull back just a smidgen. Beautiful. This is the best endoscopic surgery right here, folks. All done with a laser. All right, questions?
Okay, next question we have from Thomas Hayes on YouTube.
Hi, Tom.
And they asked, when you're at these conferences, how many surgeons are actually interested in learning to perform your technique?
0. Maybe 1. There was the one I told you about, the fellow. They're not interested. They're not interested. Because I'm going to tell you right now, this surgery doesn't pay very well. Okay? You don't make much money. I don't make much money on this surgery. As a surgeon, I don't make much money at all. It all goes to overhead. All the money. See, a fusion, you're going to get $100,000 on a simple fusion, and you're going to get 200,000, 300,000. Oh, look at that herniation on bigger fusions. Okay, so when I was doing fusions, the insurance companies would pay $100,000 to $250,000 for surgery, right? Well, surgeons make a lot of money doing fusions, and the companies that sell the screws and rods make a lot of money doing fusions. And the hospitals make a lot of money doing fusions, okay? So the laser surgery, there's no money. We may get 30,000, 40,000. That has to pay for everything, and it's just not enough. So the truth is, I saw this coming because when artificial discs were coming out, okay, back in early 2000, yeah, when artificial discs were coming out, what was happening was everyone was talking about how great they were, but the payment to the surgeon and the hospital was so low because the insurance companies weren't really paying for them that nobody wanted to do them. And I saw at these meetings that all these surgeons were saying, well, we don't get paid really to do the artificial discs. The insurance companies aren't paying. So the insurance company reimbursement is really the major driving force in these surgeries. And I hate to say it, but when the insurance companies pay so much for fusions and so little for anything else that's better, that's going to change doctor and hospital's behavior, period. And that's an undeniable fact. Okay? So what changes the insurance company? You, people change the insurance company. How? Well, it's your insurance. You have to demand that they pay. You have to fight them to get them to pay. All the new technology, like artificial discs that are paid by insurances, they're paid because patients fought their insurance company to get it paid. Or almost done. 2 minutes. Okay? You guys fought your insurance companies in court, and that is what we're doing with Duke Laser Disc Repair. We're going to court. We're going to court. We're going to take these insurance companies, we're going to sue them on your behalf to try to get them to pay. All right. Actually, let me see. I got a piece of herniation right there I got to deal with. So you can see it's sitting right on top of the cord. That is not coming out, so I'm going to have to release that herniation. Release it. Oh, yeah. Now, let's see. How much of that is herniation is the question. It looks like herniation to me. I have to be very careful here. This is the most delicate part of the whole surgery. Peeling this herniation off the spinal cord. Okay? This is what you call a through the ligament, through the posterior ligament herniation. It's literally sitting on top of the spinal cord. There's the PLL. Oh yeah, baby. Come on. There we go. Look at that, folks. That is incredible. That makes me want to cry. How beautiful that was. You know, doctors who do fusions don't even get that herniation out. They leave it. All these surgeons, they just fuse and they leave the herniation there. You just saw that come off the spinal cord. At C6-T1. First of its kind in the world. Literally making history here.
Are you done here?
I'm not done. We're just warming up, huh?
I just want to check the
Oh shit, you're kidding. You heard that too?
Yeah, I heard it.
Oh fucking hell. Hold on. Oh, it's there.
No, it's
Uh.
everywhere. There's no
Light on?
lights.
Light on?
You can see any lights. If there's
Light
no
on?
here-
Yeah, it's fine.
Yeah,
yeah.
yeah, so should be
We're just checking the fiber. You guys see the laser fiber here? It's pretty cool, huh? Can you guys see this?
Yes, we
Okay.
can.
So you guys see that little tip right there, right?
Yes.
You're looking at that in the endoscope and you're thinking that thing's huge. But look how small it is. This is my hand. My hand's big, but look at that tiny thing, okay? This is the most beautiful system. And the worst thing about it is the company that makes this stuff decided not to make it anymore because nobody was buying it except for me. And I'm trying to get them to give me everything they have and they won't do it. It's just such a battle, constant battle to try to get these surgeries done that we have to fight and fight and fight everywhere. Insurance companies, stigma, everything. I mean, anyway, we're used to it. Okay, I guess we could take another question or two. I'm almost done. I've just got to get the last of this and hopefully, yeah, I just have to be really careful here.
This next one isn't a question, but they are seeking for help or advice. This comes from Cindy on Facebook. And they said, wow, I have had 2 major back surgeries. They put 8 screws, 2 rods, 2 brackets, lumbar area. Now that I'm older, I have major problems with my upper back.
Yeah.
I have been in pain management for 4 years now. Major pain now.
We can fix your back. You come to Duke Spine and we'll get rid of your pain. We'll get rid of it with a simple procedure, and you won't have to take any more pain meds. You won't have to have a stimulator. You won't have to have any of that junk, folks. Duke Spine cures back pain with a simple procedure, either the laser or the plasma. Okay, one or the other, and they work. We're just about done, 30 seconds. I'm going to take the rest of the questions in our broadcast room, face to face, so you can see my gray beard. I'm turning 53 in just the next week. And there's a piece of herniation. We're just pretty much done. I need 30 seconds just to peek. This case is history, making history, because it is a C7-T1. I don't see any more herniation down there. It's looking really good, but I'm going to just take one more peek because sometimes you can be tricked. And I want to thank this patient for believing in us and our ability to fix her. She's so worried, so scared about surgery, and to be honest, I was scared too. Because you never know, it's always surgery, something bad could happen. But we do everything we can to make that not happen. That is the spinal cord you're seeing down there, just below. Those are the annular tear. You guys see the fibers there? All annular tear. And then there's spinal cord. And a little blue stain on the surface because there's just the tiniest amount of material there. No, we're done. We're done. You can stop the irrigation. We're done. Beautiful. Very happy with that. Spinal cord from end to end. We did it. Proud of my team. You guys are all the best. Amazing. Dr. Berndes, thank you. We made it happen, folks. So I'm going to take your questions, but in the meantime, Henry, will you do me a favor, run one more video showing how the Duke Laser Disc Repair works, and post a link for anyone who wants to get their MRI reviewed by us virtually through a Zoom call. We need your MRI images and the report, and we need you to give us some information. Give that link for the free MRI review at Duke Spine. It's mri.dukespine.com. I'm going to show you in just a moment, before you run that educational video, I'm going to show you how tiny the incision was. It was a bloodless surgery, folks. She's going to go home in an hour. No hospital, no metal in her neck. Every other surgeon in the world would have fused her or put an artificial disc. We didn't. She got the very best. Did I already suck it out? Turn it on. Perfect. So we just did a little antiseptic to get rid of her, as a precaution we do for every surgery. We don't want any bacteria in there, and we're done. I'm going to take this tube out. You guys are going to see the front of her neck, and she has a 4mm incision. It's bloodless surgery and metal-less surgery. I'm going to hold pressure for just a moment. If you want to look here real quick, this is the endoscope and camera. Can you guys see this?
Yes, we do.
Made by Richard Wolf, FDA approved. Everything we use is FDA approved. And unfortunately, Richard Wolf is just, they make beautiful equipment, engineered it, manufactured it perfect. Their organization sucks. They don't support education at all. They don't support research at all. They don't do any real training. So unfortunately, they have no money. That's why. And they keep raising the prices. That little scope right there is around 15 grand. Actually, can't even buy it anymore. They don't manufacture it. We've been searching for them. All right. 4mm incision. See it?
Yes, we do.
Look at that. Oh, my. All right. It's amazing. No bleeding. Good job. Congratulations. And let's go to the educational video, and I'll be there to answer questions face to face. My bearded, hairy face to your faces.
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.dukespine.com.
It is February 23rd, 2022, and I'm here with one of my patients who has traveled from Kansas. Is that correct?
That's correct, Wichita, Kansas.
Wichita, Kansas, and clearly you've had surgery. We just did it less than 24 hours ago. You've got your incision there on your neck. How are you feeling today?
Much better. Much, much better. 26 years ago, I had a fusion of C6 and 7. They told me in Wichita that I would need to have fusions of C4 and 5 and C5 and 6. They set up the surgery for the 23rd March, and I'm going, I can't wait that long. This thing hurts, it's killing me, I cannot sleep, and so on. My husband Dale did a whole batch of research online, and he says, I want you to be able to move your neck after surgery.
Yes.
And
I did a
he
lot
did
of
a
Googling.
lot of research, and we found Dr. Duke to be a man of integrity. He films all of his surgeries. He puts many of them online, and you can see for yourself all the good work that he's doing, and that he really, really likes to help people. What he does is generally not covered by Medicare and not covered by some other insurances, but it very well should be, because it really helps people.
So what was life like for you before surgery?
My pain was mostly in the neck and shooting down my shoulder, and especially in my shoulder.
And you had really bad weakness with your arm. You couldn't even lift your arm, right?
That's
before
correct.
surgery?
That's correct.
Show us what you can do now.
Before surgery, I could lift it to about here, and now I can lift it.
All the way
Yeah,
up.
just the next day, right
You couldn't
after.
do that before.
Yeah, that's because she had a herniated disc, two of them, C4-5, C5-6, and the herniations were literally sitting on the nerve, and we got in there, and if you watch this video segment right here, you can actually see there's the laser, and as we're removing the herniation, it literally pops right out of the foramen where it was sitting on top of the nerve, crushing the nerve. So, and the surgery was a success. We lost almost no blood at all. and you can see your incision is tiny. And here you are one day after surgery. It was outpatient, and you're ready to go home, right? You guys flying
Going
back
home tomorrow.
tomorrow? Okay, very good.
Try and enjoy a little bit of Florida today before we go back to the snow.
Okay, it is snowing there, huh, in Kansas?
Probably.
Okay.
If not today, then tomorrow.
Well, stay another week.
And yesterday it was 70
I
degrees
wish.
there.
70 degrees where, in Kansas?
Or maybe that was the day before it was 70 degrees, and
nice.
then they woke up to about 11 degrees.
Ah, so the cold front came in. We get those from time to time, and it gets cold around 60 degrees. Well, most of the time it's very pretty here in Florida. Well, we're glad you're here. Is there anything else you want to say to the world about herniated discs in the neck and surgery?
Dr. Duke will give you a free look-see on the MRI. It's well worth your time. And he will do a Zoom call with you and tell you what he can do for you. So, go for it.
I said that it was so important that I said I'd pay for it. You know, because we got a little bit of a nest egg, and sure it's going to cost a little bit, but it was worth it because we got results. I mean, that's amazing.
Your health is the most important thing in the world, people's health. So
You can't take it with you when you
yeah.
pass away.
All right, folks. We'll have a safe travels back.
Thank
Great
you.
to see you. Glad we can help you out. That's a nice.
Thank you.
That's a nice shake. This is Dr. Duke Major. I'm here with one of my patients who underwent the Duke laser disc repair on his neck just yesterday. How you feeling?
I'm feeling better, a lot better. Already, after years of chronic neck pain, I'm already feeling better within 24 hours.
So is the pain that you had when you came here, do you still have that pain?
Not that pain, it's just, I think, a little bit from the surgery itself, but it seems like a lot of the numbness and the tingling in my hands went away, and already starting to feel a lot better.
Now you had a fusion done before, not by me, and you can see the scar there. And then you had the laser surgery done yesterday. And how would you compare the two experiences?
Night and day. I actually, when I had the fusion, had to go back to the hospital with complications. And it just took a long time to recover from that. So this was much, much better.
Now, your fusion on your neck was done by a pretty famous neurosurgeon, right?
Correct.
Even with him doing it, there were still issues.
Yes.
What kind of problems did you have with the fusion?
Well, I went there for the numbness in the hand and still the chronic pain that I've had for many, many years. And it seemed to take away the numbness in my hand, but the pain was still there. So I spent many, many years going to chiropractors. I've had injections, I've had massage therapy, physical therapy, and most of them gave a little bit of relief.
Did any of them get rid of your pain?
Not completely, no. Just kind of made it bearable.
And is your pain gone now?
It's certainly getting there. I'm thinking probably within a week it'll all be gone.
And your surgery was done, even though you had a metal plate in your neck from your prior fusion, we were able to work around the plate and get in there and fix those discs, especially the C3-4, which was, you can see a lot of herniated disc material in there that was causing most of your symptoms. So I'm happy you're doing so well. And you had it outpatient, so you didn't even have to go to the hospital.
Correct. Yeah. Left in about an hour and a half.
What are you going to do now that we fixed your neck?
Well, I'm going to take care of it for the prescribed 6 weeks, and then hopefully I can start getting back to a normal life, be able to get back to golf and things I like to do. Dr. Duke and his processes here and everything's amazing. If you have a lot of chronic neck pain or back pain, I would highly suggest coming to him.
Awesome. All right, my friend. Congratulations.
Okay, great. Thank you. And now that you've had an opportunity to watch this anterior cervical Duke laser disc repair endoscopic procedure done and watch our videos and learn a little bit more about the procedure, we've just completed, we do a lot of cervical, and typically cervical disc problems occur at, sorry for the metal, that was from the metal days a long time ago. Cervical disc problems typically occur at 5-6, the C5-6 disc, then the 6-7, then the 4-5. They rarely occur below C7, almost never. And to see the next disc down, which is the C7-T1 disc, is so uncommon, but it does happen in certain people with long necks. And they don't have more vertebrae, they just have a lower shoulder. So their clavicle, their shoulder, their muscles that attach the shoulder area and the bones up to their spine, they're just longer. So when you have a longer neck, you can actually get injuries to those C7-T1 discs, which is extremely hard to get to because the collarbone right here blocks us from getting there. So if the collarbone is too high in the neck, you're not going to get to C7-T1. As a matter of fact, probably 95% of my patients, you could never get the C7-T1 through the front. This patient had a large herniation pushing on the spinal cord and the nerves at C7-T1. She had a herniation that actually went through the ligament in the back of the disc. So what ligament am I talking about? Well, this spine model shows you the bones and the disc, and look at this thing in the front. That's called the anterior longitudinal ligament, ALL, anterior longitudinal ligament. It holds the bones together and discs together in the front, and then you got a second one called the PLL, or posterior longitudinal ligament, in the back, right? So if you look at a disc herniation, it goes backwards towards the PLL. Most disc herniations don't go through the PLL, they're below the PLL, and it's easy to get them out going through the disc, right? But this herniation ripped right through the PLL and was pushing on the spinal cord, the dura of the spinal cord right behind it, from side to side. You could see that at the end when I cleaned out all the herniation with the laser at C7-T1. This is a historical case because it probably is the first in history to ever be done anterior endoscopic transdiscal. I don't think I've done one at C7-T1 in the past. Maybe I've done one, I just don't remember it because I've been doing this 16 years now. So it's a very special case, and it went beautifully. Couldn't have gone better. I was really worried about it. Now, if you want to go back and watch the first disc, which was C6-7, that was a degenerated disc. So she had a herniation, and because it was never treated with the laser surgery that we do, over time, over years, the disc collapsed and you get almost bone on bone, and the bones are stuck together. There's no movement, right? We went in, got in between those bones, through the disc, got to the back, found the herniation, and cleaned it out. So even when you have a degenerated disc, it can still be repaired properly with the laser, no problem. And then the 7-1 disc that we just did, the last one, was more of a fluffy disc, more of a soft herniation, newer herniation, more recent. And that one went perfect. So we'll take questions at this point.
All right. This one comes from Joe Latore on Facebook.
Joe Latore.
It's not a question, but it's just something just to put out in the open. Dr. Duke took me out of pain on December 23rd, 2010 via laser to my L4-5 after previous failed lumbar surgeries. Cool dude.
Oh, Mr. Latore, thank you so much. It's great to hear from you. 13 years ago, you had the Duke laser disc repair on your lower back. I still remember your face, and I think we did a video of you as well. I remember we did a video, and I could still see you right there, 13 years ago. I'm glad you're doing well. And that's the thing, people. I know you don't realize this, but we're not in New York City. We're not in Los Angeles. We're not in Chicago. We're not in Miami. We're in a tiny town. So all my patients that I did surgery on for the last 20 years, they come back to me when they have a problem. And the patients don't come back because they do very, very well. And we did a long-term study of my laser patients, and we looked at minimum 5-year follow-up. So if I had done the laser surgery less than 5 years, we weren't counting them. So we went back to people that had at least 5 years of since their surgery, and the patients we called, we had about over 60 of them, and they were having 95% of their preoperative back pain was still gone. 95% of their preoperative leg pain from the pinched nerve was still gone. So 95% elimination of back pain and leg pain, 6 years on average, because a minimum of 5 years, but the average was 6 years for the cohort, and that 95% elimination of pain. That's epic. There is no surgery in the world on the spine that gives you those results. Patients generally will have at most 20%, 30% 6 years after surgery with laminectomy, discectomy, fusions, artificial disc. But with the Duke laser disc repair, 95%. So thank you for commenting. It means a lot to me. I hope you're well. I hope your family's well.
All right. The next question comes from Sharon K. It's kind of a two-part question. First question is, where are you located? A friend says he only has only half a spine, of a spine. He's almost 40 and says his surgeon just found this out after seeing numerous doctors and MRIs. Is that possible? And with a rebuttal of from what you said with the steak dinners and the seeing the neurosurgeons, she rebutted with, "I will buy you a steak and a drink, doc."
Yeah, thank you. So one of our viewers is asking, she has a friend, I believe she has a friend who has half a spine. I'll be honest, I don't know what that means because there is no condition I'm aware of. There you have half a spine. Now, I will tell you that in the lumbar spine, okay, in the lower back, okay, right here, forget about the screws and rods. These are old models. Long story short, if you don't have bony union in the back of your spine at L5S1, it's called the spina bifida. Generally, it's called spina bifida occulta. Occulta means you don't know about it till you're an adult. And so your friend probably has spina bifida occulta, where the fusion centers during embryology, when you're making, when you're a fetus and you're still in your mother's womb, or father's womb, I guess these days. Anyway, the bones in the back don't fuse, so you only have the front half of the spine. Sorry, I'm just trying to be politically correct. Yeah, I think there are some men having babies nowadays. So anyway, long story short, it's 2023. I'm open-minded, and long story short, that may be the problem. Thank you for the offer on the steak dinner. I don't need a steak dinner from anybody. I just want to see people out of pain. That's all that matters. And out of pain with safe surgery that's minimally invasive, that doesn't use metal. All right? So yes, these are remnants or vestiges of my past. I trained at the University of Florida in Gainesville, top neurosurgery program in the world when I trained there, with Dr. Roten as the chairman, and lots of very, very famous neurosurgeons that were professors, kind of like Hogwarts if you ever watch Harry Potter. Unfortunately, when Dr. Roten retired as a chairman, there was a huge fight among these very, very big, powerful neurosurgeons who are professors for the chairmanship, and one of them got it, Dr. Friedman, and the rest of them, these very, very important neurosurgeons, left, and they all went to different places. Dr. Art Day went to Harvard to become chairman, and Rick Fessler ended up somewhere else as well, I believe in Chicago. Long story short, a lot of our faculty left at that time, but the training during that time was second to none. It was top training during my training period, and I was trained on spine surgery. So in the 97 to 2000, early 2000s, it was all about state-of-the-art, cutting-edge spine surgery to fix pain and decompress nerves. Was all about putting metal in, cages, screws, and starting of the artificial disc with the FDA trials back in early 2000, around 2000, 98, 99, and we were a center where we were putting in artificial discs in the lower back and starting in the neck. And long story short, I was trained on metal. I came out in 2004 of training, and I set up my practice, and I did a lot of fusions, a lot of decompression, realignment, fusions, and the patients did so well. My patients did fantastic. They were doing really, really well, but these were major surgeries. They were painful. It took a long time to recover. There were some complications, not a lot. My complications were usually, screws that got loose from failed fusion, or complication from BMP, for example, bone morphogenic proteins with eating away the bone. Again, complications related to implants, okay? So when I learned about endoscopic surgery and I found that there was no implants put in, no metal, no peak, no nothing, no biologics, nothing. Okay, it was just straight up endoscopic. But it was being done to treat leg pain at the time, not back pain. And when I started doing them after training, I started to see with my laser technique that people's back pain went away, people's neck pain went away. And I started to do more, and I started to ask myself, what am I doing different than the other endoscopic surgeons that were not getting rid of the back and neck pain? And I realized what I was doing was a debridement with the annulus, with the laser. And so that became the hallmark of the surgery that we do. The Duke laser disc repair includes an annular debridement and a herniectomy. We don't take the disc out. We leave your disc there. There's no reason to remove your disc. And if we take your disc out, we have to put something in its place. So we're not doing that. We're just taking the hernia out. Today's surgery, you can see us remove this large herniation off the spinal cord and nerves, decompress, and we did it all without opening the patient up, without bleeding. We did it all without complications like swallowing problems, hoarseness, that everybody else, all these other surgeons get those complications, okay? So you watch literally the best in the world doing the best surgery in the world that you could possibly have for a herniated disc. Your friend, to answer your question, I would recommend that they send their MRI to Duke Spine Institute. Let us review it. Let us, see how we can help your friend who has half a spine. I think there's more to the story than that, but whatever's causing their pain, we can fix it. Anybody with back pain out there, we can fix. There's only very rare cases where we cannot, and that would be like literally 1 in 500,000 that we can't fix, okay? Everybody else we can. So don't give up hope. If you're having pain, contact Duke Spine Institute, see what we can do to help you.
Next up is not a question, but just acknowledgement from Sharath.
My favorite pen, by the way. Go ahead.
This comes from Sharath on YouTube once more, and they said, I have all the medical records for my neck and back, plus MRI and T-scan. I have big faith that you will help me with my neck clicking and headaches.
I hope we can help you, Sharath. I really do. I need to see your films. I need to see your reports. I need to see you on Zoom. You're going to have 10 minutes with me, and I can figure out where your problem's coming from, and I can give you a recommendation for treatment. So the rest will be up to you whether you go forward with it or not.
And then last but not least, we have a question from Will Huffman on YouTube, and they asked, do y'all take LOP or LOP, LOP from Texas attorney?
Okay. Well, is that the name?
Will.
Will from Texas. Hi, Will. Dr. Duke Majan here. Will we take a letter of protection, LOP, letter of protection, for an auto accident or slip and fall from Texas? So the answer to your question is yes, but we're going to require a deposit up front. So you're going to have to talk to your attorney, and anybody injured in an auto case or a slip and fall, Duke Spine will treat you, but we have to get some payment up front, and the rest you can pay after you settle your case. So just talk to Richard here, but my advice to you is set up a telemedicine so I can evaluate your spine and look at the MRI images, talk to you, figure out what's wrong first, and then worry about all that later. Let's just make sure we know what's wrong and what we can do to fix it. Then we'll figure out the pricing and payment afterwards. That's it?
That is it.
All right, well, I hope you enjoyed the surgery. This was, for me personally, one of my favorite because we actually got it done when I had some doubts, and I'm very pleased with the result. I think the patient's going to be very happy. She's a beautiful young lady, and she didn't want a big scar in her neck. She didn't want fusion, and honestly, nobody else could fix C6-T1, so we did it, and we just completed it, and I think she's going to do fantastic. Have a great day. We'll be back. We have 4 more surgeries. Only 5 today?
Yep.
Yeah, we've been busy. I thought we had 6, but I guess maybe there's been COVID going around, so maybe one of them canceled. But 4 more surgeries. The next one is a lumbar. A gentleman who comes to us from out of state. I can't remember where he's from. Idaho? He's from Idaho. So the next patient's from Idaho, and guess what? Nobody would touch him. No one in Idaho will touch him. I'll tell you why. Just briefly, and we'll talk more about it next case. He has a problem with bleeding. He is on blood thinners, specifically Coumadin, He's got a heart valve that needs Coumadin, and he's had a prior stroke, a hemorrhagic stroke. He's had brain surgery. So no doctor will touch this man. They won't help him. He's in agonizing pain. He cannot walk. He's with a wheeled walker all the time, and he's got pinched nerves. So we're going to go in, do the laser surgery with a 1/4-inch incision, and he's going to restart his Coumadin later tonight. And that's my plan. So when no one else will help you, come to Duke Spine. We'll help you. All right? I'm Dr. Duke Majan. Henry's done a great job. We're going to have some more beautiful testimonials out for you guys this week. You should see some of the ones coming out. They're amazing. They really pull at your heartstrings.